All right, so we're going to discuss another respiratory distress case. Hopefully we'll be able to stick with this theme through some different variations over the next few case presentations. So this was a middle-aged gentleman who presented to the ED with chest pain and shortness of breath. He had a sharp onset of chest pain 3 days ago with associated shortness of breath. He felt like that had been increasing over the same time period. Wasn't able to really say what made it better or worse, just that he felt it was getting worse. He had also had some mild leg swelling, which he kind of reported as a chronic issue. He also noted that he had a colonoscopy a few weeks back, and that was followed by 2 weeks of blood in his stools. However, after 2 weeks, that stopped. His review systems didn't really show anything else other than his shortness of breath, chest pain, leg swelling, and abdominal pain. Physical exam, very hypertensive, had a chronic history of that along with chronic kidney disease. Heart rate and respiratory rate looked good. He was satting well on room air. The gentleman really did not look distressed. Didn't look like he was having that difficulty of breathing at all. Was able to speak in full sentences, looked well, like I said. He did have some very trace lower leg edema, but no JVD. Some very faint rels in the bilateral lung bases, nothing significant. And then he had some mild tenderness in the epigastric region, but there was no guarding, there was no rebound. Like I said, the gentleman looked fairly well, but these were new onset symptoms for him. When we talk about the shortness of breath. So, here's the question is, what do you do with this patient? Somebody that's had some hematochezia, who's short of breath. Clearly this could be anemia that's causing this. Also, could he have unknown heart or lung disease? He is a little bit older, has had elevated chronic blood pressures for a while, but he looks well. So I personally think that we underutilize cardiac ultrasound and lung ultrasound in the emergency room. My particular institution, sometimes we over-rely on a portable chest x-ray, which is not that great, and could use, definitely a 2-view would be better. However, I still think lung ultrasound is able to show some detail to us that we don't get from the chest x-ray. So with that said, I've proceeded with an ultrasound. I like to start with the cardiac ultrasound and then proceed with a lung ultrasound, typically. So we're just going to go through the quick views of what I saw. This is the actual study and images that were saved for that. So we can see here's the LV, you can see the wall thickness. And we're just going to go through the questions here. And so our typical questions binary are, is there cardiac activity, which of course there is. How's his EF? This is collapsing pretty well. It looks like it's collapsing well. It's a little hard to see on this video. On the machine it was easier. But the valve's flipping up and hitting that septal wall. Looks well. So is the EF normal? I think so. And then, is there a pericardial effusion? I don't appreciate one. I don't see anything along this back wall here. And then, is there anything else? So on this view, I like to look at the LA here and note if it's very big. I don't see the aortic root real well, but this just does not look big. I usually like to compare them. They should be about the same size. But we can see in other views what it looks like. So moving on, then rotating the probe to the left shoulder, we're able to get a peristernal short access. If I wanted to talk about image quality, I could have turned down the gain down here, could have decreased my depth a little bit, but still going to answer my clinical questions. Here's my LV. And I imagine putting a dot right there, and this is really collapsing well towards that dot in the middle. So I go back to my questions. The EF appears normal. I don't appreciate a pericardial effusion. And in this view, is there anything else I noticed? One thing I like to pay attention to in this view is how big is the RV? Does it look like it's wrapped around the LV, or does it look like it's, two shotgun barrels looking at you? And here, it looks appropriate. It's not a big structure, looks appropriate size. So nothing really notable there. Then we go to an apical view, and in this apical view we can see the inner wall. We can appreciate a little bit more how well he's contracting. The EF looks good here, so when we go back to our questions, EF looks good. I don't appreciate a large effusion. Now remember, this is not the best view for appreciating an effusion because it's not the gravity dependent portion usually. And so no large effusion here. And then, if we consider anything else, I personally in these, even though it's a little beyond basic cardiac ultrasound, if somebody's short of breath, I like to put color flow over here, and that's what we're going to do here. And I like to see for mitral regurg. Sometimes that can be a person's issue. So as I look here, here's my LA. I'm just looking posterior to this to see if I can see any blue jets coming back. And unfortunately in him I do not. Now one thing I did not appreciate at the time of the exam that I noticed at a later time, that we look here, and here's our aortic outflow tract, and we can see the blue going away. So BART, blue away, and red towards. And if we watch this blue go away, right here we can see this red coming back at us. And I don't recall noting it before, but it looked like to me, the red's coming from here, and I didn't give it second thought. But if you actually watch, the red's coming from over here on this side of that valve leaflet, this anterior septal wall leaflet. And so right here, this is actually atrial insufficiency coming back into the LV, which could definitely be contributing to his symptoms here. So that's something I noted at a later time, but wanted to point out for the rest of you to be able to see that. Then we go to the subxiphoid view. I think the thing that I appreciate here, so we're going to go through EF again of the left ventricle looks good, looks normal. I don't appreciate a pericardial effusion when I look here at the lower pressure side of the heart. Nothing here, and I definitely don't see it down in here. And then if we get to, is there anything else? The LV just looks thickened to me. The walls look thickened, which would go along with his chronic history of hypertension and what we saw in the ED that day with his elevated blood pressure. And then we're able to look at the IVC, and we're going to look right here. We see some movement up here, but we're going to evaluate about 1 centimeter distal to the hepatic vein. And right here I don't see a lot of collapse of those two coming closer together. So this could represent fluid overload, but mostly what we need to remember is it represents an elevated CVP. Now we did not test on this particular exam for any right-sided valve issues, and within basic cardiac ultrasound it's not typically within our scope to try to get or estimate pressures of the right side of the heart. But this is able to tell us that he's got an elevated CVP and then we can use that data at least to objectively with other data to determine what's going on. So here's a M mode tracing. I just took that down at that same spot and traced it, and we can see our numbers here. So 1.86 to 1.61. You can calculate IVC collapsibility index, but clearly not decreasing more than 50%. I personally like to just visually watch it, but here this supports that it's not collapsing a lot, and our CVP is going to be high. So my ultimate read on this was a normal ejection fraction or normal cardiac activity. I did not appreciate a pericardial effusion. There was a distended non-collapsible IVC, which is a rough estimate of an elevated CVP between 15 to 20 plus. And I noted the LV appeared thickened, and then at a later time, like I said, I noticed the aortic valve insufficiency that was there. So possibly that could be causing a shortness of breath, but I like to use lung ultrasound in conjunction with cardiac ultrasound. And we're just going to take a quick look at this. So just a refresher, because I don't have the little icon up here, or a little drawing, but here's our rib, and there's shadow, these black areas, anechoic areas behind it. Our pleural line's right here, and we can appreciate what's going along that pleural line. So our question here is there lung sliding? Yes, because we can see the B lines dancing. And then, is there B lines present? And we can definitely see some B lines dancing around here. We can see some happening up in here also. So as we move to the lower lung fields on that right side, this is towards your head. this is toward your feet. We can see B lines in this rib space, occasional B lines here, and B lines down here, and we can even see them up on this rib space up here. Jumping over to the left, definitely a lot of B lines. We can definitely see them starting here and projecting all the way down. One of my colleagues, Dr. Brad Jackson, likes to call them flashlights, starting with the beam here and coming down and spreading out. And I think that's a good analogy of what the B lines look like, or lung rockets, but clearly more than 2 to 3 per rib space. And if we come down here, this is a still image of what they look like still. I didn't obtain a video here for storage space reasons. So right lateral, same thing. We have a rib space and a rib space, and we see more than 2 to 3 B lines per rib space. And then our lung base, we can appreciate that there's some B lines going along this pleural line. Our diaphragm's coming right here, and we can catch a glimpse right here, the diaphragm, and we notice that there's a little anechoic region right here, which means there's a small pleural effusion, and here is our liver here. So to get a still image of that, you can see the diaphragm coming here. Here's the effusion, liver's out here, and we see that spinal line continuing up above here, and that keys us into that pleural effusion being existent. Not a big pleural effusion, small, but it is present. When we look at the left, more of the same. B lines here, flashlight stick, or B lines coming down, or flashlight beams, more than 2 to 3 per rib space. Left lung base, more of the same. And we get a little bit of the spleen here on this. Here's our diaphragm coming around like this. Here's our lung coming down into view. And we can trace just a little anechoic stripe coming here and concentrated there. So there's another pleural effusion. So bilateral pleural effusions for this gentleman, in addition to his interstitial syndrome that's going on. So what was our read for this? So the lung ultrasound showed lung sliding present with diffuse B lines, which is consistent with an interstitial syndrome, and in this case, likely pulmonary edema, and then bilateral small thoracic free fluid. So overall, when we use those two together, this could be non-cardiogenic pulmonary edema, but I doubt it with his thickened LV and that aortic insufficiency. So this is likely a diastolic heart failure with a normal left ventricular systolic ejection fraction. And this is keyed in by our dilated non-collapsible IVC. Had that not been present, that might be, calling into is this non-cardiogenic pulmonary edema, but I think that supports it a little bit more, and clearly pulmonary edema. Of note on him, his hemoglobin had dropped 5 grams since he had that colonoscopy. So the question, also is, was this, high-output cardiac failure, for example, for trying to compensate for that anemia that had developed, or what part had that played in it? And the patient was ultimately admitted to the hospital for further care and to be started on the right medicines for both his cardiac failure and further evaluation of his anemia that had occurred. So jumping back here, we're just going to look at pulmonary edema. I think, the question is, how did this help when this patient had multiple comorbidities? I think implementing ultrasound early can at least get you pointed in the right direction. You do have to be careful not to pigeonhole yourself into diagnoses, but definitely doing it early in the evaluation can give you an idea of what's going on with that patient. It is a data point along with everything else that can help you best care for the patients. In this case, it definitely led us away from some diagnoses as far as pneumonia and just anemia being the only issue, which could have been easily mistaken, and blood given without considering his pulmonary edema. Those are definitely key elements here as we look at this patient in particular. But the benefit is this was something that was found out on the initial evaluation. A quick history and physical were done, and this was done fairly quickly from the initial time the patient's information was entered till the last image was obtained on the lung ultrasound. Was a total of 12 minutes. So right there at bedside, we were able to get to a good idea of at least a significant contributing factor to his shortness of breath and what was going on with him. I hope this case helps. This is a little different than the pulmonary or the pneumonia that we did last week or prior, but is definitely a case that we see frequently in the emergency room. I'd highly encourage using cardiac ultrasound and lung ultrasound in conjunction when evaluating shortness of breath. I often kick myself for not using it, and just find that it's very helpful when evaluating undifferentiated shortness of breath, especially early on in the presentation. Once again, I hope this helps, and appreciate any comments. Feel free to subscribe, and hopefully we'll have more interesting cases coming up. Thanks.